Hello friends, welcome to another session of Radio Shots, and today we'll be talking about a very interesting and a very important disease entity from the point of view of gynecological imaging. We'll be talking about two different cases coming to us with similar complaints, and we'll be trying to understand the pathology and the radiological findings. So let's have a look at our first case. Our first case is that of a 24-year-old female who comes to us with dysmenorrhea and infertility. The married life of the female patient was around 2 years. Now, the patient was sent to us for a transvaginal sonography. I want you to have a look at the transvaginal sonography and I want you to answer at least three basic questions. First of them is to explain the findings. I want you to have a look at the transvaginal sonogram. I want you to observe the case, make your own findings, and try to formulate a report. The other things I want you to know is adhesions and deep involvement. Now, this is one of those disease entity which is associated with implants in the pelvis, and this is the reason why we can have adhesions and we can also have deep involvement. So what is the disease entity which presents with dysmenorrhea, infertility, deep involvement, adhesions? Let's try to decipher it with our cine loop. So this is the sonographic cine loop. I want you to have a look at this particular case. So when I'm going towards one head and neck, I can see a cystic lesion. This is the midline. I can see something which is located posterior to the uterus. And when I'm maneuvering towards the other side, I can see an ovary, which is also not looking normal. Now I'm gently maneuvering my probe in the axial direction or the transverse direction. Again, I'm taking the mid-sagittal direction or mid-sagittal image of the uterus. What are the important observations that you have made from this particular case and what is your professional diagnosis? Let's try to understand the finding from beginning. So as I'm just maneuvering my probe from this direction to the other direction, I can see that there is a very well demarcated cystic lesion located in one of the adnexa. Now this cystic lesion is showing homogeneous low level internal echoes. And I hope that all of you would now identify it as an endometrioma or a chocolate cyst. Then when I'm slowly maneuvering my probe towards the midline, I can see something which is dysmorphic, irregular soft tissue, which is present posterior to the uterus, and to be more specific, it is located at the junction of the cervix and the uterus. Mind you, this is the site of torus uterinus. This site is the site of attachment of uterosacral ligaments. And when you have a patient who's having dysmenorrhea, who's having an endometriotic cyst, then this amorphous soft tissue is likely to represent a deep infiltrating endometriosis. And if you see carefully, what is this area? This is the area where the vagina is intersected by the rectum. Now I'm calling it vagina because I can see the cervix still here. So the fornix would go deeper somewhere here. I can see this particular soft tissue extending up to the posterior layer of the vagina, and I can also see it in relation to the rectum. Now, let's go further ahead and look at the other adnexa. So when I'm looking at the other adnexa, what do I see? The ovary looks slightly irregular. I don't see the ovarian surface normal and smooth. I do see a follicle, which is again showing some low-level internal echoes. High possibility of an endometriotic follicle. Along with it, I can also see some echogenic specks, very small echogenic implants over the ovarian surface. And if you would have observed, then on the contralateral side also, we could see that there were some echogenic implants which were located on the ovarian surface of the ovary, which was showing the endometriotic cyst. These are nothing but chronic blood degradation products and surface endometriotic implants. So what are the important observations that we have made till now? One of the important information is endometrioma. The other one is a deep infiltrating endometriosis located in the region of torus uterinus, which is adhered to the uterosacral ligaments. And the other ovary is irregular along with presence of surface endometriotic implants. Now let's go ahead further and let's decipher what else is here. Now when I'm maneuvering my probe in the axial direction, so this is the uterus as you can see, and this is the right ovary, this is the left ovary. What do you see now? We can see that there is some hypoechoic soft tissue which is present in the region of the torus, which is adhered to this ovary as well as this ovary. and this is pulling both the ovaries in the midline. So this is the classical appearance of kissing ovaries. So the other observation that we've got is kissing ovaries, which represent nothing but inter-ovarian adhesions. One more important thing that you might have observed till now, look at this ovarian wall and the cirrus of the uterus. Both of these ovaries are also tightly clustered to the respective uterine serosal surfaces. So we have another type of adhesions, that is uterus plus ovarian adhesions. So to begin with, this case looked very simple. This case looked just like a case of uncomplicated endometriosis. But once you would maneuver your probe gently, once you open up the patient's pelvis, then it's just like a Pandora's box. You can get n number of information from this case. So to complete the discussion, let's just quickly swipe through the last image. And what do we see here? In this particular image also, we can clearly see that there is this deep infiltrating endometriotic implant, which is irregular, and this is actually adhered to the anterior serous of the rectum. So this brightly echogenic layer is basically the fat which is separating the rectum from the deep infiltrating endometriotic implant. So you can see this rectal wall being pulled towards the endometriotic implant anteriorly. So this is a classical appearance of the rectovaginal nodule, which is characterized by deep infiltrating endometriosis located at the level of the rectovaginal septum. So I hope this case is going to be clear to all of you. And now you would formulate a structured report where you not only write ovarian endometriosis, endometriotic cyst, surface endometriotic implants, but you'll also write about the presence of deep infiltrating endometriotic implants and at least these two or three important type of adhesions, that is interovarian adhesions, adhesions between the ovary and the uterus, and adhesions between the rectovaginal nodule or deep infiltrating endometriosis with the ovaries, rectum, or the uterine serosa. So once you're clear with this case, let's now move on to our second case. And in the second case, I would want you to answer all the questions that I've answered in this particular case. So this is a case of a 23-year-old female with dysmenorrhea, infertility, similar complaints. And again, I would like you to answer these three questions. That is, explain the findings, how would you formulate it in your reports, and then presence of adhesions and deep involvement. Let's have a quick look at this particular image. What do you see here? You can see the uterus, and I'm just maneuvering my probe from one side to the other side, and I can see a significant abnormality in bilateral adnexal regions. Now, let's play the video from the beginning. So what do we see? This is one of the ovaries, and here I can see that there is one cyst here, one cyst here, both of which are showing homogeneous low level internal echoes, a very high likelihood of an endometriosis. Then, if you see the position of this ovary, where is it located? It is located just posterior to the uterus. It means it is located in the pouch of Douglas. Another very important clue to the presence of endometriosis and adhesions. The ovaries would be seen free in the adnexal lesions, but if you see them very close to the uterus or in the pouch of Douglas, in presence of prehistory of dysmenorrhea, think about endometriosis. Then when I'm maneuvering my probe towards the other side, what do I get? In the other ovary, I have a clear cut sign of endometriosis. What is this sign? Here, I can see a large endometriotic cyst. I hope all of you will be able to identify it. But there is something else, and brownie points to the person who can tell me what is something else which is associated with this particular ovarian endometriotic cyst. So if you see carefully, what do you see here? This black colored structure which is having feathery and spiculated margins, and this particular structure which is present just posterior to this hypoechoic tissue is nothing but the rectum. Yes, you're right. It is again an example of deep infiltrating endometriosis where an endometriotic implant is present in the rectovaginal septum, but it is also there to one of the ovaries and the rectum posteriorly. So it is a case of a deep infiltrating endometriotic implant with adhesions with the ovarian surface as well as with the rectum. And there's one more thing. What is this? Just adjoining the ovary, we can see that there is a dysmorphic structure. Now, anything which is present adjoining the ovary, which appears almost mixed echogenic, slightly hyperechoic, in a patient with endometriosis or infertility, always think of a dilated tube. So this is nothing but is a thick walled and strongly adhered dilated fallopian tube, which is stuck to the ovarian surface. So I think all of you would have got what I've said till now. How would you report this? You report it as a case of endometriosis, which is affecting the ovaries. You can clearly see endometriotic cyst in both the ovaries. You can clearly see adhesions. adhesions between the ovary and the uterine surface, adhesions between the deep infiltrating endometriotic deposit and the rectum and one of the ovaries. So this is all about endometriosis, what you need to report specifically in cases of deep infiltrating endometriosis and its relations.